This is QD Clinic, and I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.Live. Shorter lectures, more discussion, more review. Be there. Today's case is Molly's in trouble. Molly's a 57-year-old gal who has rheumatoid arthritis for about 3 or 4 years. She's doing very well on what you've prescribed, which is leflunomide, 20 a day, abatacept given weekly subcutaneously, and she PRN takes meloxicam if she feels stiff or she's going to do more. When she was last seen about 6 or 8 weeks ago, her CDI was 4. She calls in saying that for the last 4 days she's gotten worse. She now has swelling and pain in her knuckles in her left hand. That would be MCPs 2, 3, 4. She sends a picture in, looks kind of full, not really rare. She did have a similar kind of flare a few months ago, and that was treated with a few days of steroids. She's seropositive RA for a few years. She also has depression and osteopenia. So what's your treatment preference? What are you dealing with? This is clear-cut RA. Could it be something else? Could this be infection? Unlikely. She's had a flare like this before. Could this be drug-induced lupus presenting in an RA patient? Well, that would have to be on a TNF inhibitor, right? It doesn't. Otherwise, you don't get drug-induced lupus in patients with RA. What about just a simple plain old flare? That seems to be the preferred diagnosis here. Your treatment options are many, yet most of you play the steroid poker game. That's a title from Marty Cavanaugh, who did a blog on RheumNow saying, when confronted with, these urgent situations, we play steroid poker. What are you going to do? What am I going to do? Is my regimen better than yours? What trumps what? Because we're never all the same. Our steroid management of flares is kind of like an art that we invented, while driving home one day. So you could give a Medrol dose pack. That would be starting at 24 milligrams a day, going down to 4 milligrams a day over 6 days. You can give prednisone, 10. Some would give 15. A few would give 20 for 5 to 10 days. You might do an intra-articular steroid injection if it was a joint that you could easily inject. I would do that in large joints. I wouldn't do it in MCPs 2 and 3. Would you instead use things like immobilization, rest, and ice? In the good old days, hospitalization and bed rest was a common treatment for RA flares, and you know what? It works. It lowers acute phase reactants. It makes swelling go away. Would you manage this with, non-steroidals or other analgesics? Most people wouldn't, unless you were going to be on bed rest. Waiting it out doesn't seem like a reasonable advantage. That patient's not likely to come back to you. My point is that flares happen frequently, yet our management of flares is a little bit of a game and a little bit of an unknown. Flares happen when you're tapering DMARDs or biologics. Flares happen with pregnancy, with surgery when they're off therapy. They can happen like this patient from either who knows what or a stressful event or an intercurrent illness. And if you're managing this by phone, who knows if this is fibromyalgia or flare? Now, telemedicine, pictures that are good pictures or a face-to-face visit would answer that question. But you do need to know that flares are not innocuous. Flares don't have a guideline. They're not in the 2022 EULAR guidelines. They're not. There's no provisions for them in the ACR 2021 guidelines. The facts are that most RA patients are going to flare. Even RA patients in remission, 30% will flare. There are studies that show that most flares will last a week or less in 60% of patients and more than 2 weeks in 30% of patients. The problem is during flares, without calling you, over a third of patients and maybe a half of patients will change their medicine without your advice. There are a number of studies that show that those who have flares and repeated flares are at greater risk for cardiovascular events. They're at greater risk for radiographic progression. And, all the rheumatologists say, well, not if it's a 2 or 3 day flare. If it's a 2 to 3 day flare, you don't really need to use steroids, do you? Well, then yes, we do, and yes, we don't. My point is, I'd like to minimize the steroids. I'd like to maximize the rest. and yet I'm looking for another regimen. One is not in play. So who's going to do the study that shows alternative ways to manage flares? Maybe you manage it with short-acting anakinra or short-acting JAK inhibitor, or most biologics, most DMARDs won't act fast enough to appease the patient. That's why rest, ice, and something that manages pain. The problem is most patients want to keep going. So how do you manage flares? Maybe you should do this study. Think about it. That's it for this episode of Cutie Clinic.